Hello, this is Dr. Latasha McElwain with Insightful Options. I am giving you an overview today of the ASAM criteria. With this overview, you will learn more about the ASAM criteria, why we use the ASAM criteria, and how to use the ASAM criteria. This will be part one of the ASAM criteria overview. This video is for supervision purposes. It's to help professionals understand what the ASAM criteria is, and again, how to use it and other aspects of it from this presentation. My contact information, drlatashamcilwain.com, www.insightful-options.com, and www.greenmcelwainfoundation.org. So again, just want to welcome everyone. This presentation will provide a foundational knowledge of the criteria and how to use it. The training will provide each participant with a firm understanding of the criteria. Objectives of this criteria, of this ASAM criteria, is to introduce the system change of the ASAM criteria, and then also talk about reviewing the paradigm shift and what led to the ASAM criteria, discussion and apply the ASAM criteria's decision-making process, identify and describe the 6 ASAM criteria assessment dimensions, rate risk and severity across all dimensions, identify services and modalities needed and treatment planning approaches, identify appropriate patient level of care, discuss special populations and emerging research about addiction, and develop strategies develop strategies to overcome real world barriers as the ASAM criteria is implemented. So basically look at those strategies and then trying to come up with those real world barriers that are involved and wanting to try to implement what we're actually putting out there when it comes down to the ASAM criteria. All right. So for the introduction here, the ASAM criteria is designed to help clinicians, counselors, and care managers develop patient-centered service plans and make objective decisions about patient admission, continuing care, transfer and discharge for individuals with addiction, substance-related, and co-occurring conditions. Through their multi-dimensional assessment and the continuum of care, the criteria care improve patients' outcomes. So basically, how patients how we're able to use this criteria and be able to work with our patients, we're able to improve the outcome of the services that we are providing when we're looking at going from the assessment to the services we're providing, continuum of care, and then the outcome of the person completing the services and possibly being referred to other services, whether it's a discharge or continuing care where they're doing their step-down plan. All right, the ASAM will improve the quality of and access to addiction care. So ASAM is there to help us ensure that we are providing the services, quality services that are needed to our patients, and that they are able to access those services. We're talking about the admissions to service planning to level of care. So admissions to service planning to level of care. When we're talking about everything that goes on in that gamut, we're looking at the intake and the assessment. So the intake information sometimes is different from the assessment information, but a lot of times intake and assessment go hand in hand. From there, we look at service planning and placement. So we're looking at service planning, how we're going to provide a service or what services we're going to provide, and Also kind of figuring out, thinking about the goals and things of that nature. We're talking about service planning also. Goals, objectives, things we want to implement in the services, the plan for services. The level of care placement, that's talking about what level of care this person really meets for services. We're going to talk about that when we're talking about withdrawal management, when we're talking about the placement level, level of care placement level, and also we're talking about special populations. So I'll give you an example right quick of that. We're talking about level of care based on placement. We're talking about whether a person needs inpatient or outpatient. We're also talking about whether an individual is needing to be in withdrawal management because they are withdrawing from a substance that will cause them to go into probably medical withdrawals or go into any other type of scenario when we're talking about withdrawal symptoms. So being able to manage those symptoms is something that's very, very needed and very, very important, because sometimes people can go into a withdrawal symptom that could possibly cause them death. So we always want to make sure that people are being managed appropriately when we're talking about withdrawal management. And then the level of care placement, again, talking about inpatient, outpatient, whether it be intensive services, whether it be residential services and things of that nature. And then when we start talking about special populations, we're talking about maybe a patient that came in, yes, to have the substance use issues for the most part, but they also may be diagnosed with HIV or AIDS. So we got to be mindful of the special population there. Could be a woman that might come in. This woman might have some different issues that are going on. But this woman could possibly be pregnant also. So we're thinking about special populations. We might be talking about a adult that might be coming through services, but that adult has IBD concerns and issues. So we might have to be mindful of that as a special population. So we got to be mindful of different special populations that do come through and the level of care that they're needing. It could be an older individual, or elderly individual that we may come across that might be in a situation where at home they can't do all of their ADLs, and we're talking about a placement program for them, a residential type placement program. So we would have to be looking for a residential placement program that probably have medical care on staff or have CNAs available for services, because even though that person is recovering from, addictions, they also have some serious medical concerns and issues that are happening, that for them to be at that residential place, they're going to need more of a medical type facility or whatever the case may be. So it's a lot of different things that go on in thinking about, how we're going to do the level of care in that placement. All right. So emerging understanding of addiction. So yes, definitely talking about what we have to start understanding about addiction. I hope me just giving a little bit of that information just now, those special populations are things that kind of come into mind when we do think about individuals that are dealing with addiction, because people come from all sorts and all different types of walks of life. So yes. Moving right along, we're going to talk about the system change. We're going to talk about the ASAM, individualized clinical driven care. So management team, from there, we have to look at how things have kind of transferred out into as far as services go. We have from your management team, you typically have performance appraisals. You have clinical staffing meetings, you have policy and procedure, you have process of intake and assessment, and then you have paperwork design. So how the paperwork and everything set up. Other side of that, you also have individual and group supervision. You have group size that you need to be mindful of when you're doing kind of like those ratios and how many people in group and how many, individuals we need to have in a group setting. And then the lecture scheduling, like who's doing the groups, who's doing the lecturing, and then the training, basically a small piece or a small step, but the trainings for, of course, ongoing training and being competent with the services that we are providing, so that the counselors know, what they're working with when they're working with our clients, and then staffing schedule. So those are some of the things that happen when we're talking about the management team, and we're trying to make sure we drive home that individualized clinical driven care for our clients. So we want to make sure we're mindful of some of these things and make sure that we're putting forth the effort to make sure that we keep up and keep things, I like to say, on a clinical level. Business, I like to say business is business, yes, and our what we do for a living is business for, for quote unquote business owners and folks as well. But for us, there is a clinical component to what we do, and that's how we try to manage ourselves and manage ourselves in business and manage ourselves and making sure that we're providing a level of care. So we're trying to make sure that we are providing an individualized, clinical driven care for our patients. Moving right along and talking about the paradigm shift. So, the paradigm shift, we're going to talk about pretty much diagnosis, program driven treatment, making sure that we got a good diagnosis or a reasonable diagnosis. Not reasonable, but the correct diagnosis, as correct as possible, with diagnosing, and then going into driven care treatment, making sure that we are program driven treatment. We are making sure that the program is, there, and we know what the program is, and the care is driven in that area. But we also want to start making sure also that we are dealing with our diagnosis, deal with our programming, and dealing with our aftercare services. Those are all important, yes, but that's where the paradigm kind of shifts a little bit, where we are trying to make sure that we are focusing on our clients also. We're doing that individualized care. When we talk about individualized clinical driven treatment, we're going to go to the point of understanding about patient, basically how they participate in the assessment, being mindful of that, being mindful of the data from the biopsychosocial dimensions that we get from the individual. We also want to be mindful of the problems and the priorities, things that are going on in their lives. The biosocial, the biopsychosocial, psychosocial severity, and the level of functioning for the individual and the services that we're providing. The plan, and then we also want to look at the biopsycho social treatment intensity and services, the modality and level of services. Again, we're looking at whether they need inpatient, whether they need outpatient, whether they need to be meeting 2 times a week, whether they need 2 times a week could be intensive services. Just depending on whether they need residential, long-term residential, short-term residential, whatever those residential areas are. And then progress, and then response to treatment from the psychosocial severity and the level of functioning. So those are other areas and things we have to think about when we're trying to create an individualized clinical driven treatment. Not necessarily, but I would say not necessarily with that program driven treatment, but the clinical driven treatment. Basically, what does this client need? Individualized and definitely clinically driven. So looking at the guided principles of the criteria. So key terms, when we're talking about the criteria here, we're talking about the ASAM criteria. Key terms we're going to look for is multi-dimensional, which covers relevant areas of the person's life. So different parts of their life, whether they're a mom, whether they're a dad, whether they got kids, whether they don't have kids, whether they got a girlfriend, whether they got a real tumultuous relationship, they got a marriage and a girlfriend. I mean, just different things that happen in people's life. They got a job, they work three or four part-time jobs to make a full-time job. They, just all kind of things that happen, family issues, family of origin issues and concern. Children might be, a child could have special needs or something, or they could have a teenager that's out there using drugs themselves, or, it's just a lot of things, a lot of dynamics there. They could have really smart kids that are in college and, they're trying to work on getting themselves together because their daughter's getting ready to be a lawyer, or, getting ready to graduate from law school, or, so there's so many different things that are going on in people's lives that we want to be multidimensional. So those are just a few things I just wanted to throw out there. Then we're looking at individual care. So planning according to each patient's need with unique strengths, need, and goals, which is critical to every stage of the decision-making process. And this, I would say, is very important because we do have to think about the individual care of everyone. Like I said just now, this one might be over here dealing with a teenage daughter that's promiscuous out in the street expecting the first baby, and then this one might be dealing with a daughter that's getting ready to graduate from law school. This one might be dealing with a son that is in prison, and this one might be dealing with a son that's the president of Bank of America. I mean, I'm just using that for an example. So these are just different things to be individualized, to realize that the care still have to be individualized, and they have some unique strengths in their situations, and they have some specific needs depending on what's going on, and specific goals depending on what's going on in all of those situations, again, in all the multidimensional parts of their life. So that's important. And then more from treatment failure. So treatment failure is a prerequisite for more intensive level of care. So basically, if a person's doing outpatient services and then all of a sudden they start using again or whatever, then we can probably bump them up to intensive outpatient, which means they're meeting 2 or 3 times a week. And then after that, if they fail at that as well, then okay, we can bump them up to maybe an inpatient, or maybe a 7-day inpatient, or a 30-day inpatient, whatever the case may be. We're just bumping their level of care up. And so that's real important to understand and know, as well as in moving the move from treatment failure. So whatever treatment fails, then we have to figure out what's the next level of care that we can kind of go up to try to get this person the services that they need. Because outpatient is not working, intensive outpatient didn't work, inpatient for 7 days didn't work. Okay, now we need to look at a 30-day program. Now we need to start looking at a 3-month program, 6 months program, 90-day program. We have to start looking at these different levels of services. And then when we're looking at adolescents, we got to be specific with the needs. So due to difference in stage in life, we have to be mindful of where adolescents are emotionally, cognitively, physically, socially, and the moral development. So basically, what adolescents may think, or what adults know is this, an adolescent might not know that. They don't think that far in advance, and that's not a part of their moral makeup hadn't really been, or is being challenged, but is not really set and developed yet. So, we have to be mindful of that when we're dealing with adolescents. Also, informed consent. We have to be mindful that providing the patient with clear information enhancing the working relationship and increases collaboration, as well as shared decision making in a team. So we want our patients to really trust us and understand that we are looking out for their best interests, and we want to be genuine in our services and providing a good genuine service to people, and make sure that they understand that we do care about them. So then variable length of services, I kind of mentioned that earlier. Treatment is often time driven. So yes, treatment is often time driven. We're dealing with insurance companies; they're definitely time driven. But then also when we're dealing with certain programs, they're definitely time driven. I'll give an example. If you're doing a DWI program with one of my agencies, what we typically do is we cannot complete your treatment in less than 30 days if it's a 20-hour program. So you still have to come to class at least once a week for the next 4 weeks before we're able to give you a completion. Same thing when you get 40 hours. We can't do it in less than the 2-month period. So, and you can't have it completed in less than 60 days, but you can have it done right at 60 days or over 60 days. So based on that, basically the ASAM criteria conveys that the length of service should be based on the progress of the patient is making. So with that being said, yes, the services should be based on the progress the patient is making. But I do think when we do look at the ASAM criteria, they're still being mindful of the fact that addiction ain't gonna change overnight. So just because you can, whisk your way through 20 hours in 1 week, don't mean that you got it. You will probably go out and have a relapse. So just that being mindful. And then I tell people too, well, you can't take 6 months to do 20 hours either. You know what I'm saying? So we got to be mindful of those things. But I think we come in as the clinicians to try to make sure that we're helping people understand that we're trying to get you better. We're not trying to put you on a timetable to get in, a timetable to get out. We want you better. We don't want to have you have to come back through our doors again or go through somebody else's doors again for the same issue and become a revolving door for you. So that's pretty important to think about. Next one here, more guiding principles for the criteria. Broad continuum of of care, of continuum or care. So I think it's supposed to be of care. I'm sorry. The ASAM criteria advocates a broad continuum of care to meet the diverse needs of patients. So yes, again, talk about those diverse needs. Everybody have different needs, everybody have different situations and different scenarios, so we are going back to that multidimensional approach that I mentioned earlier. Interdisciplinary approach, making sure that we have the complexities of the team so that we can have these different professionals in place to help promote the recovery. That would be pretty much collaborating with psychiatry, collaborating with a medical doctor, collaborating, if they got diabetes or something, collaborating with a medical doctor. It's just a lot of different areas. Collaborating with a therapist, collaborating with a nurse if there are medication that need to be given that a nurse have to administer. I mean, just all those different things, that just so many complexities. And now we also think about from the interdisciplinary approach, we also think about the case managers. We think about the residential facility that the person is going to be living at. We think about the community agencies involved, the probation officer, the other services that they have in place, the peer support specialists, all these other people that are in place. That's your interdisciplinary approach, which we call our multi interdisciplinary team. All right. So now, moving down to medical necessity care for the psychosocial severity in all six of the areas of the criteria assessment dimensions. And then the last two here is talking about guided principles of the criteria. The role of the physician, they play a vital role in supervising and managing treatment. Their skills in diagnosing can be helpful in working with co-occurring conditions as well. So if we're dealing with someone who has a whole lot of medical issues and using substances, or maybe even have the mental health piece that's really playing in as well, just a lot of different things there to think about. So goals of treatment, the goals of treatment ought to be basically altering the course of the patient's disease, however, towards wellness and recovery. So whatever we're doing, we should be altering the patient's the course of their disease that is pushing them towards and pushing them forward to the wellness and recovery state. All right. So I'm going to the ABCs of addiction. So when we start talking about the ABCs of addiction, we're talking about A is abstain, and it speaks to the inability to consistently abstain. B talks about the behavior, speaks to impaired in behavior control. C, craving. D, diminished recognition of significant problems. And E, talking about the emotion part, the dysfunctional emotional response. So that's kind of what our patients are truly dealing with, and we have to be mindful of that and totally being understanding to what's going on and how to help them work through many of these concerns, work through the fact that they can't stay clean, they can't stay sober, they have behaviors that are impaired and out of control. So a lot of these things come into play. Cravings happen. So yeah. So moving right along, we're talking about treatment planning. When we start talking about treatment planning, so treatment planning is a process that starts at the assessment. So treatment planning, basically, we start figuring out kind of things that may be needed for this client day one, and we start talking to them about it when they start talking to us. So counseling and treatment planning are not separate events. So basically, counseling and treatment, it is together. The treatment planning all together. The counselor usually helps develop the treatment plan, so it's all together. The biopsychosocial clinical interview is the assessment. The prior treatment information is up in there as well. We're also talking about the collateral data that we're collecting, the patient goals, and we're also looking for any type of testing, any assessment tools that we're using with the patient, or anything that the patient has had in the past. The ASI talking about games, talking about social assessment and other tools that gather clinical information. I use the ASIMV, which is it's an assessment tool that definitely works with substance abuse. They actually, that was for addiction, and they actually have one that's the BHIMV, which is the behavioral health one as well. So it's a lot of different gamuts in there when we're talking about treatment and we're talking about treatment planning. Moving right along with treatment planning, we're also talking about the dimensions, admission criteria rules for appropriate level of care and the type of services. So basically, knowing what those dimensions, admissions criteria rules are for the appropriate level of care and types of services is what we have to use to make sure we're appropriately planning for the treatment. We're going to look at the dimensions 1 through 6, and then we're going to also talk about the dimension analysis. And then we also want to make sure the treatment plan is created and we are considering all of these areas as we're doing this. All right. While we're doing all of this and trying to figure out working with clients, we also want to be mindful of imminent danger and immediate needs. So imminent danger components basically is a strong probability continue to use and having behaviors which will lead to relapse, or B, the likelihood of the behaviors and actions will create significant risk of serious adverse consequences. And then C, the likelihood that the adverse event will occur will occur in near future within hours to days versus weeks to months. So that's more of the imminent component, imminent danger as we're looking at it. And then we're looking at immediate needs, any area of immediate need for the patient, anything that they say that they need, or anything that we can identify that they need, or we can kind of talk through and figure out what that need is like, and make sure it's something that is an immediate need versus being in the danger area, risky, dangerous, intimate area. We definitely want to make sure that we're taking care of that. All right, so let's talk about 6 dimensions here. We start talking about 6 dimensions. Dimensions 1, that's going to be acute intoxication and or withdrawal potential. So those are, like, for us at the hospital, when I work at the hospital, we are looking at acute individuals that come in with acute intoxication. They're, right now having issues, they're intoxicated, they have a lot going on. And then the potential for the withdrawal symptoms, all that good stuff, that's in dimension 1. Dimension 2, we're looking at, okay, what is going on with this person emotionally, behavioral, cognitive conditions, and complications. So those different areas, we're trying to figure out what is going on. That puts us in dimension 3. And actually, I think I skipped dimensions 2. Wow, I think I did. I skipped dimensions 2. Well, we're going to go ahead and locate dimensions 2, and I'm going to talk about it. But we just mentioned dimensions 3. And then dimensions 4, I can see here, is readiness and change. And then dimension 5 is relapse, continued use, and problem, and continued use and continued problem potential. And then 6 is the recovery environment. So I am reaching so I can grab my information here. But when we're talking about addiction and we're going through our different levels of the dimensions here, we normally would have all of this, have our dimensions here 1, 2, 3, 4, 5, 6. But again, like I said, I look like I missed one, but I think I have it down here. So we're going to move on, and I'm going to come back to dimension 2 in a second. So, exactly. All right. So I'm just going to jump forward right quick. Dimension 2 is the biomedical condition and complications. So we're going to jump here. And so the 6 dimensions, the first one is the acute intoxication. The second, dimension 2, is the bio and medical. Yeah, biomedical conditions. Yeah. And then dimension 3 is the emotional behavior cognitive condition. Dimension 4, readiness to change. Dimension 5, relapse and continued use or continued problem potential. And then Dimension 6 is recovery and environment. So I'll go back and put dimension 2 on this slide later. All right. Dimension number 1. We start talking about dimension number 1. We're talking about the acute intoxication or withdrawal potential. So at that point, we're at risk of intoxication. There are also some detoxification going on. What substances and what substances are being used? How much and how long? So these are some of the questions that we're going to be going through with the individual. Dimension 2 is talking about the biomedical conditions and the complications. What is the focus of this dimension? What are the key questions for this dimension? So we're going to be asking them a lot of key questions about what are your medical conditions? What medications are you on? What medications you have been on? What type of medical concerns you've had in the past? What have you been diagnosed with in the last 6 months to the year? What is a chronic illness that you may have and things like that? So we want to know what's going on. 3, we're going to talk about emotional behavior and cognitive conditions and complications. So for this one, what is the focus of this dimension is what we're kind of, looking for. What are the key questions for this dimension and what are the risk domains? So we're asking them, what has been going on in life? Do you have friends? Do you hang out with friends? Do you have family support? What's the relationship like with you and your mom? What is the relationship like with you and your wife? How are the relationship with you and your children? Have you been to school? What's your, did you graduate high school? So we start asking a lot of questions around that area, but these areas help us to figure out kind of where we're going. Have you ever had going back to the medical one from dimension 2, we'll ask them if they ever had a TBI, if they ever had a brain injury, okay? Going to dimension 4, readiness for change. What is the focus of this dimension and what are the key questions for this dimension? So a lot of times readiness to change, what's going on in life that now you're coming to treatment, and you're coming to treatment for what reason? And, what would this reason do for you if you're able to get in here and be able to be successful in your treatment? So you just run through questions that I'm kind of using, but it's more specific and precise when we look at our clinical assessment. So I'm just going through some basic information here as I'm giving this presentation. When we talk about relapse, continued use, and continued problems, so we're asking them questions like the folks that I mentioned right here. We're asking them questions like, when was the last time you used? How much you used? We start going through all that, and we're trying to just make sure that we're getting a good idea of, how many times have you tried to use and didn't stop using, or try to make those cutbacks in your using and things like that. So we're asking a lot of questions around there, and that's a lot of good questions that we do ask in a clinical assessment that helps us to formulate our clinical summary of what's going on with this patient, or giving us a real good clinical overview of this client or the clients. So then we look at the recovery environment. So we focus on this dimension. This dimension is really kind of focusing on like, okay, so what's the recovery environment like? Are you going to go back into a community where everyone around you drink, or everyone around you smoke, or everyone around you in your neighborhood, or whatever the case may be? We want to know more about that, because the recovery environment is going to be very important for a lot of our clients to make sure that they're going to stay on track. And some of the key questions is, do you live in a house where you have support? Do you live in a house where you have, and some of them might say, well, yeah, I live in a house that I have support, but I live in a house that's very stressful. Or I live in a house, and because I'm the only one that's using and drinking, then it feels like it's just more stress on me because my sister and brother seems perfect. It's just a lot of dynamics to, go with. And when I say that, I'm talking about older adults sometimes that, yeah, they're 3 or 4 generations living in one home, and, a sister, brother, and another brother can live in the house, and they could be out working and doing everything all day, but our client stays at home all day and helps with the kids here and there, but they're too drunk or too high to really, so the rest of the family kind of talks down to them, or whatever the case may be. And that probably have another thing, when we're talking about that failure to thrive area. So again, recovery environment, that's important. Okay, so decisional flow. So basically, when we look at the decisional flow, we're looking at the intake, assessment, questions, discussion. We're looking at service planning and placement. We're looking at questions and discussions. Then we're looking at the level of care, treatment, we're looking at questions discussion. So basically, things start to flow in a way that we're going to start making decisions as for what's going on. Intake assessment, then we're looking at the service planning and the placement, and we're at the level of placement. Okay. We start looking at the severity, assessing the severity and the level of functioning. Basically, these are questions that will go back into someone's history. We want to know what's been going on in the past. We want to talk about what's happening here and now. And then we want to know how worried now. So, how worried are we now about this issue and kind of moving forward to a point of getting to or having to move forward to that point of getting to a better state. So we definitely want to look at that when we're considering assessing the severity and the level of functioning. When we're looking at the risk rating. So when we're talking about risk, 0 would be no risk at all, no issues. 1 would be mild difficulties. 2 would be more moderate difficulties. 3, serious stuff going on. And 4 is the utmost severity of imminent danger, that things could really ravel out of place real fast, you know? And I like thinking about the ASAM because the ASAM actually puts me in the mind of how I work in the hospital setting. So in the hospital setting, if we see a client that comes in regularly and we kind of know their baseline, then we're able to look at the risk level and the risk rating a little bit more better than just clients kind of, coming in and out of the hospital and we don't know them like that. And we do get all the information, just like I'm talking about here. We get information from collateral. We find out what's going on, who they live with and how things going at home. Is it a supportive environment? Can someone watch them and watch them under supervision? And like I said, we in the hospital, we get all patients. So when we're looking at the ASAM criteria, we're doing the ASAM criteria on everybody that comes through our program. And everyone that comes through, if substance is involved, we definitely are going to be looking at that to make sure that, we can address the ASAM criteria with our assessments. So I say that to say, even though we might be talking about somebody with mental health and it's not a substance abuse issue, we're still asking all these questions to find out what their recovery environment is going to be like, and who they're going to go home with and what the family got to say and what happened, even though we're saying we're talking about mental health per se, just a issue of depression. But we want to make sure that person is going to be safe the same way. So I love the way, for me, my substance abuse side also complements my mental health side, and my mental health side complements my substance abuse side. I just wanted to say that. So so as I'm thinking about these, I like to, in the risk side, it gives me a good idea of understanding the risk level. For me, it complements my mental health side to my substance abuse side, my substance abuse side to my mental health side when it comes down to my knowledge, expertise, and my education and everything else in my trainings. So when we start talking about level of cares, substance abuse area, of course, we have a nice little chart of our level of care for services. So more stable and more compromised, that's where it goes from. So being very stable to being very compromised in a situation. 0, no issues at all. 1.5 would be early intervention. When I look at the substance abuse side of stuff, 1.5 early intervention, and the work that I do in my private practice, that's a education level for us. We tend to provide people education. We provide the Prime for Life classes to individuals in the early intervention area. When we get to level 1, that's the outpatient case. So that's a case where we're going to be, that person is going to meet the criteria for outpatient services. Same thing if I'm inside the hospital. If I'm talking to someone and we're talking and they're not in imminent danger, but they have some concerns or whatever, we're going to make everybody a referral. Everyone that's going to leave the hospital is going to leave a referral for outpatient services if they're leaving the hospital on a discharge basis. Discharge as in they're not being referred to inpatient treatment. So, excuse me. Moving right along, and when we're talking about level 2, we start looking at, excuse me, intensive outpatient, and that's that can also be, excuse me, that can also be partial hospitalization services. Now, intensive care, intensive outpatient
could be where you're going to the facility 2 to 3 times a week, probably for 2 or 3 hours per day, or just 2 or 3 times a week that you're going. And then partial hospitalization is where you're going probably 5 days a week, and you're probably going for an 8 hour stint. So you're going to treatment in that time frame, and that's your intensive level. And it's outpatient, of course. Partial hospitalization means you go to the hospital, you check in, and you check back out that evening. You go home, you sleep, you come back, check back in 5 days a week. All right. So from there, we move into 2.1, which is the intensive outpatient services. And that's another way where we also can bring you to a program 3 days a week, 3, 4 hours a day, you know? So that's my understanding of all that. When we're talking about 2.5 actual partial hospitalization services, we're talking about you again going every day, getting out, going for about 8 hours every day, 7 to 8 hours every day, and getting out. It's almost like going to a job, but you go to your program from 8 o'clock to 5 o'clock that evening. You get out, you go home, you have dinner, you still kind of, in the world, in the community and stuff, and then you go back to treatment the next day. And 3 level, we're talking about residential inpatient. So we're looking at residential inpatient on the 3 level. Of course, residential, we're staying there. Inpatient, we're staying there as well. So same thing when talking on level 3. 3.1, the clinical managed low intensity residential services. So that one is more where people are lower in the intensity of what they need in the services. When we're talking about 3.3, we're talking about the population specific. We're talking about specific high intensity residential services. So it might be some particular things that are going on within the service that definitely have a high intensity that's going on there. And then you get to 3.5, we're talking about high intensity residential services, meaning you need all that care, and really being, really need to be taken care of. And then we start talking about 3.7, that's the one that's medically monitored. And we talked a little bit about that earlier, about a person that might have diabetes or high blood pressure or different type of ailments and things like that nature, HIV and AIDS, different things of that nature could fall into that area, as well as in they're having some real complications and some problems. And then, so the intensity of their service and their inpatient, they need more care. And then the medical, medical managed intensive inpatient service is meaning that they definitely have to be monitored more. That's up to 4. Okay. So these levels do change with the services that are being provided. And I want to jump back right quick. I know when we talk about residential services, when the hospital where I work, we're talking about inpatient care. The inpatient care where I work, we have low level inpatient, where a person could just be depressed, anxiety, just a lot of stuff going on for the most part. Maybe those adjustments where they might be going through a divorce. There might be something that's going on in their family. Someone died. So those individuals might be on a lower level intense when we're talking about intensity, when we're talking about an inpatient stay. Individuals that come in with, again, different issues and different concerns might be on a special unit or whatever the case may be. And they could be possibly, when we say special unit, that could be maybe a dual diagnosis unit or something like that. And this is my experience from the hospital, the way I'm using this right here. And then when we talk about the high intensity, and I'll say high intensity as an inpatient service, then we're looking at the fact that that person has a lot of issues and a lot of stuff going on. That might be our paranoid schizophrenic diagnoses. That might be our severe bipolar issues. That might be our major issues where they are in a real bad episode this time, or whatever the case may be. So that's our real intense clients that need a lot of care and a lot of support. So I look at it that way when I think about the levels of care. And of course, like I said, I'm in a hospital setting and I do outpatient services. So I do a little bit of all this good stuff, as well as work within some residential levels of care as well for adolescents. So just seeing all this stuff does, come together and make sense. And like I said, complements my mental health side from my substance abuse side to my mental health side.
And then again, I'm also mentioned that criminal justice plays into the back of some of this right here, especially with substance abuse and sometimes with mental health as well. And then we, and I've been in that area as well with being a probation officer and working within the jails. So a lot of this stuff resonates with me when I'm going through this presentation. I've done it, done this presentation several times. I've done this presentation 7 times. I have attended this same presentation many times to get the ASAM training. All right. So again, withdrawn management levels of care. So we're talking about the management level of care, more stable to more compromised. Again, we're talking about, 0 issues, one ambulatory withdrawal management without extend on-site monitoring. So off-site monitoring would be here. And then 2, ambulatory withdrawal management with extended on-site monitoring being on-site, and then 3 would be the residential inpatient withdrawal management. Okay. The next one here we're looking at is clinical management, residential withdrawal management. We're looking at the medical. Okay, that's 3.2, and then 3.7. We're looking at the medically monitored inpatient withdrawal management, and then 4 would be medically managed intensive inpatient withdrawal management. All right. There are also special services. We're going to look at the opioid services. So for the most part, when we start talking about the opioid services, we're going to different areas of the substances. This is one of them that's pretty big, and we tend to use this one just for the understanding of kind of what's going on in the world today. When we're talking about the opioid services, the opioid program is the medication by clinic. So medication is being administered by the clinic. They go into the methadone clinic on a daily basis. Office-based treatment could be medication by prescription filled elsewhere, meaning that you can go see a psychiatrist and he would go ahead and prescribe you Suboxone, or he'll go ahead and prescribe you Subutex or something like that. So you're going to the pharmacy to pick this medication up. And then the rest of them, these are just kind of given the different, the methadone, and then also given the not natural excuse me, Natronex also. So a lot of times with all of this, we're looking at these different areas where we can be able to assist individuals in getting their services and getting their care, and then making sure that they're able to take care of themselves in the event of anything else happening. So when we're moving right along through, when we're going back through and talking a little bit about opioid management, I do tell people we have to be mindful that opioids are, to me, it's a very dangerous drug to be dealing with. But there's so many different ways when you're dealing with opioid addiction. So for the most part, with a lot of our opioid patients, I try to make sure that they all have I forgot what you call it, the Narcan, so that if there is a accidental overdose or something like that, they're able to get those as well. So we do educate people about that as well, being in the field. So moving right along, talking about treatment plan review. So the treatment plan review, we create and update the treatment plan based on the dimensional and emissions criteria. So based on what's going on with a patient, and also depending on what's happening, what's changing and things like that, we try to keep our treatment plan updated. We check on the progress with the goals, progress notes and stuff for the goals, the objectives, the methods, what's happening. We try to make sure we have those progress notes there that we can see that there's progress being made. If there's not progress being made, if this person is regressing. So summarize treatment plan progress with continued stay review, identify new issues, and when transferred or discharge criteria is met. So we're definitely going to make sure that we're reviewing the treatment plan to make sure we are on top of what's going on with each of our patients and making sure that each of our patients are being cared for properly. When we're talking about continued services or transfer or discharge, we're going to make sure that we are being on top of if we're continuing services, where we send them, what are we doing, well, how are things going, whether they're making progress, if there's no progress, and then if they no progress but no, was made, but the person was able to make progress in the current level of care. If there's new problems, but they can be handled in the current level of care. So if there are things that are going on and the person end up in a situation where they exceed our level of care, then we have to go ahead and transfer them on or to another program, or move them into the correct services that they need. So we have to make sure that we are you know being on top of that. And then of course, if the person has meet all of the criteria and all the goals and everything else that they've been working on, then they will be discharged from the program successfully. A lot of times we do discharge with the aftercare plan. So a lot of times we are considering what they're going to do after that program to keep them going. Transfer or discharge, of course, we're looking at they achieved all the goals. We were if we were unable to resolve stuff, we're going to be able to talk about that, and they might not be discharged or whatever the case may be, or they might be transferred to a different service, so they can go ahead and address that a little bit further. Lack of capacity to resolve, if they are unable to resolve it because of whatever is going on, we have to be mindful of things like that and make the necessary changes of continued care that we have to consider as well. And then we're talking about new problems needed, different level of care. If they find out something else is going on or something else happens that's really causing a breakdown that the current level of care is not going to be able to handle for them. Okay. Special populations. Again, we're talking about older adults. I mentioned the elderly earlier. I mentioned the criminal justice setting earlier. Persons in safety sensitive occupations. Some of our people might be in different careers that we have to be mindful of that. Law enforcement, different things of that nature. Parents and prospective parents, we have to be mindful of that. Our mothers, pregnant women for the most part. Um, Barriers to implementation. We're talking about the barriers. We're talking about different things that's going on that's going to stop us from being able to implement what we're trying to do. So placement disagreement or case presentation. So if things, working with that team, making sure that it's something that can be, it goes across the board when you're doing the treatment planning. Placement disagreement, I can think of that as far as sometimes my clients don't agree with the services that I tell them that they need to be rendered at this point based on this assessment. But with that being said, we are only going to give them we're going to give them the least restrictive services that they meet the criteria for. We're going to try to go as least as possible before we jump to something else. But if they need that something else, we are going to put them in that service. So yeah, I might have a disagreement with a patient, but we work out and we tell them what they need. And of course, I'll say on the mental health side of that, when we get to this disagreement, we start looking at IBC in a person. We have to do the IBC process. Again, we have to do that on the mental health side as well as the substance abuse side, especially if they are at a point where they are a safety concern to themselves, a safety risk to themselves, or a safety risk to others. So identifying some barriers you see that can get in the way of achieving effectively using the ASAM criteria. So yeah, we got to talk about those things. We got to be able to identify them and have conversations. And what are some of the options you have for overcoming these roadblocks? So coming up, I like to have good conversations with the team and with the clients. We can come up with identify some different things that would be good to help with those roadblocks and keep us moving, where these barriers can be broken down so we can move forward and get them some care, and we'll be able to implement the services. All right, so implementation strategies. So least complex to more complex. So identifying your organization's level of care, understanding what level of care we have available for the individual. Complete the ASAM implementation lead support too. So we'll definitely, look at making that happen. And then giving the patient copies of their treatment plan so that they can understand what's going on. I like to go through the treatment plan with the patient so that they'll know what the next step is and they won't be too confused about what's going on. I don't kind of like seeing people and then not giving them a full rundown of what's happening next. I can only tell them, when I'm in a hospital setting, I can tell them, okay, the next step is that you're going to see the psychiatry team. Or the next step is I'm going back to talk to the doctor because I don't think you meet the criteria to meet the psychiatry team. Outpatient, your next step is 20 hours of treatment. Your next step is Prime for Life, the 16-hour program. Your next step is 40 hours. Your next step is inpatient care. And I'm going to go ahead and recommend that for you. But those are conversations I'm having, and why I always do a justification as to why they meet the criteria for whatever it is I'm giving them. And then also patients reviewing the treatment plan in a group. So patient review the treatment. Basically, when you're reviewing the treatment plan, you can review the treatment plan with with the treatment team group. Or a lot of times I like to do it if I have another person with me when I'm doing my services. I'll check with that as well. Making a list of whom or why the ASAM criteria is important for your agency. So understanding why it's important. Knowing that the implementation of, having the ASAM there is something to help your agency make good clinical sound judgments as far as treatment services that are being rendered and treatment services that you actually provide. Educating staff, so all staff understanding why we use the ASAM criteria. Patients understand that we do use the ASAM criteria, and the referral source of the criteria. So why we use the criteria, and why we put all this in place to make sure that our patients are very well aware of what's going on. Adding the dimensions number to the treatment plan, that's something big too. Adding the dimension to the framework, to the assessment too, and the clinical summary. So being able to give a good clinical summary of what's going on, adding these dimensions as in what's going on with our patients will give us more uh, good use of the ASAM. And then determining if the services is co-occurring, enhanced, or co-occurring capable. So we definitely want to make sure that we are, jumping in. And there, when you go through the ASAM, the full ASAM book, it'll give you more of the information. But like I said, this is just an overview. So I'm kind of, overviewing some of this information. I'm not going in depth with a lot of it. So achievement of goals in the treatment plan determine length of stay. So basically thinking about the length of stay and making sure that you achieve the goal in that time frame. Next one's the intensity of services can be seamless, increased, or decreased within the level of care, and then adding dimensional framework, diagnostic, and dimensional framework, diagnostic, and dimensional admission criteria to the clinical summary. So all that information will be included in, as well as the assessments are a patient's choice. So the patient, they get to, talk about the different things that's going on. And it's, they can choose certain things as well. We try to make sure that we are assisting patients, based on, we do tell them what our services are and what we do. I usually try to tell patients a lot of times, you came here for a service, we're going to provide you what we provide. And then we can talk a little bit more about what you're actually wanting also as we're going through all of this. So that, but we have to give them what our policy, what our procedure is to understanding you came in, so we're going to give you what we give. You know what I mean? So a lot of times the treatment is for the purpose of focus for the group, family, or one-to-one treatment. So making sure that everyone's on point about what's going on there. Implementation plan. What is your goals for using the ASAM criteria in your work? So basically using the ASAM criteria in your work is to make sure that we are definitely taking care of our clients, giving them the right level of care, not giving them too much care or too little care, trying to be on point when we're giving them the correct level of care, the appropriate level of care. And then also, what are some small steps you can take to achieve this goal? That is going definitely through I would say your assessment lineup for what you're doing for work, making sure that you're covering everything, you're getting the collateral, you're listening very intensely to make sure that you're not missing anything or no stone goes unturned. A lot of times in the hospital we go under every stone. I could work with one patient on a full day, a full 12-hour day. I could be working with one patient and still not be finished by the end of my 12-hour shift. So a lot of the clients, that's how it is typically when you're working with them, and you have to pass it on to the next shift. But I try to wrap up everything in my one shift, but I can't. I try to definitely make sure that I keep, moving forward and can come back and pick back up right where things left off. I try to tell, if I'm in there with families or with a person, I'll tell them I'll be back 7 a.m. tomorrow morning. I will check on you after I get in, or blah, 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 just to make sure that they, know that overnight no one's really going to do anything regarding their case until the next day. So what are some concerns you have about implementing the ASAM criteria in your work? I really don't have any concerns for mine, but I would like for everyone to think of what concerns they would have. And I want everybody to think about, how using some of this stuff would be helpful in what they currently do, because it does make sense for me, of course, in the different areas that I work in, to use the ASAM criteria to definitely make sure that clients are where they need to be and they're getting the services they need. And again, everything is kind of clinically driven for the client to get the care that they need. And then how would you address these concerns? So basically, how would you work with your clients? How would you want to figure out, even in your agency, how would you want to deal with some of this stuff? How how confident are you in using your abilities with some of the stuff that we've talked about with the ASAM in your everyday work? Again, like I said, I pretty much use ASAM a lot in my everyday work. Whether I'm in in the hospital, in my private practice, in my nonprofit, in many different areas that I actually do work in, I'm always somewhere or another implementing and understanding that the ASAM criteria, the setup, is still something that I consider, and take wholeheartedly to when I'm working with clients, because I want to make sure I am treating all clients, of course, with dignity and respect, and being genuine with them and letting them know the truth and kind of where we're going with things. What could you do to increase your confidence level? I would tell anyone, this is just me saying, I would tell anyone to make sure that you are competent in what you're saying and what you're talking about, and you let people know. A lot of times I know I can be inside the hospital and I'll tell them, well, this is what I know that is going to happen, but that's not saying how I give it to them. I say, this is typically what happens, but I'm not saying this is going to happen, because every day different providers come in and things do change. So if I'm telling you, I believe you're going to be, seen by my psych team, and the psych team will decide what they're going to do. You might be inpatient, you might be outpatient. I'll give them a rundown of everything just to help them understand. And I feel confident about what I'm telling them, because I tell them that I'm making no promises, but this is what usually happens. But this could be a different time where it might not happen. So I try to be real open with my patients, and I talk to them a lot. So that's how I build my confidence level. I really try to make sure I'm on top of my game and what I'm talking about, and my competency level is up to here. But I always tell them I've seen other things happen. I've seen weirder things happen, because I've seen some patients where I'm like, oh my gosh, I think they should be inpatient. And my psych team will see them and they'll say, no, they're going home. And I'm like, oh, okay, then, but even that, I tell professionals, when you have someone over you that's telling you, what else is going to be done or whatever the case may be, it's just humbling yourself down and be like, okay, whatever your decision is, you're over me. So you have the final say. Whether you say stay or go, that's totally up to you. It doesn't matter to me one way or the other. But I know that I did my assessment based on the clinical information I was given. And I'm giving this client I'm giving this client my true opinion, and my true opinion said they should be inpatient. But if you're saying they should be outpatient, that is fine and dandy also. If they come back, then they know they'll be inpatient again if the problems continue to persist. So, I'm real open with that. And I try to be real open with my providers. I try to be real open with my patients. I try to be real open with everyone, the family, so that everyone will have a kind of an idea of what's going to happen. So that's a big thing for me. That's a big pet peeve for me, just making sure to increase your competency level by being very honest and being very genuine, and being I always tell people, unapologetically just who you are, and and telling them what it is. And I know some people look at me and say, well, aren't you kind of not agreeing with the hospital policy? I may not be agreeing with the hospital policy, but I'm letting them know what the hospital policy is. I may be agreeing with the hospital policy, but I still got to let them know what the hospital policy is. So it doesn't matter what I think. It's what the family wants and what they need. And I have to put forth the effort as in letting them know the truth. And that's one of the things that I walk into all my patients with, whether they're inpatient, outpatient, wherever I'm seeing them. I try to tell them, I'm going to give you the good, I'm going to give you the bad, I'm going to give you the ugly. I'm going to give you everything, because I don't want you to say that Dr. McElwain didn't tell me, Dr. Latasha didn't tell me. So I try to be real, open with my patients. And that's a big part of me, is just being real open and understanding and truthful with my patients. And like I said, give them the skinny on everything. So that builds my confidence level. So for anybody else, you can think about different things to help you increase and build your confidence level when you're working with families as well and working with individuals. So a lot of the resources here, everything that I spoke to came straight from the ASAM. This is nothing new. This is nothing made up. It's just me giving an overview of this whole ASAM criteria presentation and what we typically are trying to do with the ASAM criteria. So again, there is a ASAM criteria entire book that we work from. I have two of those books, the ASAM criteria books, and those books, it's the same book, I think, same edition too. But I keep two of them on hand. I keep one for the hospital, and I keep one in my bag for the hospital, and I keep one in my private practice. So I try to make sure that at all times I am being very considerate of the ASAM criteria and knowing what they are and working them out in what I'm providing level of care or services with my clients and helping them understand what's going on. So again, like I said, this is an overview of the entire ASAM criteria. And I hope this is something that gives you some good insight and some understanding. Like I said, this is just a run through of just 40 something slides here, a more intense session of ASAM criteria would be needed if you're feeling like you're not comfortable with what's been said here. This is information that, like I said, is directly from it. And I just wanted to put it in a PowerPoint form so you'll be able to understand when you're considering and hearing about the ASAM criteria, that you're understanding and you're going forth in providing services and understanding how to use the ASAM criteria. But for the most part, if there are more questions, you can definitely make contact with me. I did put my contact information up here. You can make contact with me. I can get you connected with other individuals that do the full ASAM training. And I could also get you in for a one-to-one if we need to, or a group setting where I would go into more greater details about some of the information that's in here for the most part as well, as far as the ASAM criteria go. Like I said, I've been in several of the trainings many times, and I have conducted this training many times. So just wanted to put this information out there just for professionals to be able to see and hear it again. So if there's anything at all, again, I'm Dr. Latasha McElwain, and you can definitely reach out to me if you have any concerns. I hope you enjoy the rest of your day, evening, night. Goodbye.